Good afternoon, good evening, good morning for some of you. I'm very grateful to be here, to be invited to speak by Maya Payne on this last webinar. My name is Janey Prodoehl, and I'm going to talk to you today about the past, present, and future of physical therapy and TMD. But before we get there, just a few words from Maya Payne. You're going to receive a link to this recording today, so no need to take notes. You can always go back to it at any point. If for some reason you're having some audio issues, the best way to combat that would be to log out and then to log back in again to see if you can correct the problem. Also, if you have any questions or comments as we go through the presentation, we're going to get to those at the end, so please put those in the questions box as you go, and then we will moderate those at the end. Maya Payne Seminars has done a really tremendous job with this series of webinars that have been completely free. I know for me, it's been one of the highlights of my quarantine experience. So I'm really grateful to have had the chance to participate as a participant and now as a presenter. We are collecting donations to benefit the Futures Without Violence organization. So please, if you're able to, when you receive that link in the email from Jan, please go ahead and provide a donation on your free will. And then finally, as I said earlier, this is the last webinar, so but definitely stay tuned. Jan has some amazing things planned, as always, so stay tuned for new opportunities as they come around. So just a little word about me. As I said, my name is Janey Prodoehl. I'm a physical therapist. I trained in England. I grew up in England and trained my physiotherapy degree in Leeds. But now I live just outside Chicago, Illinois, in the United States, and I've been here for almost 30 years. The university I teach at in the doctoral physical therapy program is about 20 miles west of Chicago, and we're an all-graduate medical school, dental school, and allied health professions. We do have a sister campus in Arizona as well. And as part of the university, we have a multi-specialty clinic where we get to see patients from medical, dental, physical therapy, speech, etc. And then the third arm of my job, apart from teaching and seeing patients, is to do research. And I have a particular interest in looking at movement-related problems and understanding how pain changes the motor system to change movement and movement control. I have some studies that are interested in looking at orofacial pain and the effects of posture, and for that we use motion analysis. We have an 8-camera system. And then I've recently started to get really interested in the use of real-time ultrasound for capturing changes in muscle morphology and the function of muscle during activity. So I'll share just a tiny bit about that with you a bit later. We do use the ultrasound, real-time ultrasound in our clinical practice, but I'm starting to get interested in it from a research perspective. And then I usually use EMG as well as a window into the nervous system about timing of activations, etc. So just kind of by way of background, I wonder in some ways if this is not similar to your story with temporomandibular disorders, and that is how do you get started in this? Because when I was doing my entry-level physical therapy training or physio training in Leeds, we did not cover the TMJ at all. We kind of stopped at the neck. So when I fast forward to practicing in the United States, I was here about 7 years, working at a very busy outpatient physical therapy clinic in downtown Chicago, really vibrant, bright clinic with a lot of sports athletes, most professional teams, etc. It was a really exciting place to work, and nobody was seeing anything related to TMD or TMJ as it was known at that point. Because I was the newest therapist there, I got the patients that nobody else wanted. And on my caseload one day came a young gentleman about to be married who had some problems opening his mouth. And I had absolutely no idea how to treat him. But luckily our clinic had a textbook by Steve Krause, and I was able to do a quick brush up because there was no internet at that point to find articles to guide me. Unfortunately, I was really not very successful in helping that individual, but it started me on this journey of wanting to know more and to understand this area of the body. And I'm grateful to say that almost 30 years later, if he came to my clinic now, I think I could have really helped him. So I will forever be grateful to him. But I wonder if your experience with this area is any different from mine, that how much experience did you really get during your training actually working with patients? So even if you had didactic training through your education program, did you really get some hands-on experience working with these patient groups? So I'd just like to talk today about some kind of like the past, the present, and the future. Where have we come from? What do we learn from that? Where are we now? What are some of the evidence-based approaches for both diagnosis and treatment on a more general level? And then talk about some results from a couple of studies that we've done that have looked at outcomes from both the diagnosis and the intervention perspective, and then spend some brief time talking about what we might be able to apply to this area of the body that we've learned from other areas of the body. And then we'll take questions at the end. So we're going to start with the past. We're going to talk and set the stage for this problem. So these individuals often obviously have pain. It's most common their presenting complaint. But how many people are we talking about? Is this a very large percentage of the population or a small percentage? Although this is a study from 1993, I think the numbers are still fairly valid. And that is, they did a random sample of 46,000 households in the US to try to determine the prevalence of orofacial pain among those groups for over the past 6 months. And it would be no surprise to you that the most common type of orofacial pain that people responded to was tooth-related pain. But the other one would be temporomandibular joint pain. So these are self-identified as having pain in the side of the face. The cost of treating those temporomandibular joint problems in the US has been estimated to be anywhere between $2 to $4 billion, depending on if they count direct and indirect costs. But obviously these patients, because they have a higher tendency to become persistent chronic pain individuals, have a higher likelihood of absorbing more healthcare costs than some other conditions. So it is a problem, but not all of those patients will seek treatment. So if we define TMD as any disorder that involves the masticatory muscles, that's the masseter, the temporalis, and the medial and lateral pterygoids on both sides, or including the joint and the joint structures, which could include the capsule, the ligaments, the disc in between the two joint surfaces, the condyle, etc. That definition of temporomandibular disorder was actually adopted by the American Dental Association back in 1983. So the term has changed from having TMJ to having TMD, but it's been slow to gain acceptance. There's still people that refer to it as TMJ. But TMD is just the broader term. It doesn't really guide treatment in any way, shape, or form. So it's estimated that somewhere around 12% of the population may have signs or symptoms, but again, not all of those individuals will seek treatment. Some of those individuals will have a momentary problem, and then over the course of a week or so, their problem will resolve and they might not have it again. Other patients, though, have a tendency to become to the more of the persistent or chronic pain condition. And we tend to think about those patients or patients who have an acute problem in their function, maybe they can't open or close temporarily, as the ones seeking out treatment. And it's estimated that about 1 in 5 of symptomatic people actually seek treatment. And what the treatment they tend to seek depends on their knowledge of the area. They may go to a dentist first, they may go to a physical therapist, they may go to their primary care doctor. It's a bit of a mixed bag. So all of these people have some significant problems affecting their life from the temporomandibular pain or limitation in function. And it's all of these things that you see on the screen. Starting with the top left, obviously that's taking a large bite, but any action that involves repetitive motion of the joint, particularly with force against chewy foods or tough foods or crunchy foods, could be a real problem. Moving to the middle left, obviously drinking, swallowing, and then further down to the bottom left, that would be talking. All of those involve motion of the joint and activation of the muscles in the facial area. Moving to the bottom right there, we have the kissing a baby, but also kissing a partner or showing intimacy. That can become affected. And then over here, this resting face. Your face is the front that you put onto the world. And if you're in pain, if you're clenching, if you look angry, all of those can change the way that people perceive you and can change the way you are perceived. This middle one, we're even moving our jaw. The temporomandibular joints are moving even while we're sleeping. We know that some people have nocturnal bruxism or nocturnal parafunction, but even if you don't, you're still moving your jaw as every time you're breathing in and out. So it's estimated that this joint is moving anywhere from 4,000 to 7,000 times a day. And then we would look at this top right-hand corner. If you're in pain, if you're having trouble opening or closing your mouth, this can really start to impact your desire to keep up with your oral health and your oral hygiene, which can have some significant health consequences. We know that when we introduce bacteria into the mouth and we can get periodontal disease, then that can lower your resistance to fight other diseases. So it can have a profound impact on your health. And in fact, during the COVID quarantine in the States, at least in Illinois where I am, dentistry shut down to routine healthcare, to routine cleanings and non-emergencies for at least 6 to 8 weeks. And there was a group of the medical professionals that lobbied the ADA to get the dental professionals back sooner because they were worried about the potential for detrimental health because they believe that dentistry is so very important in helping our patients to stay healthy. So TMD can impact basically all functions of your life. If we think about to your personal history and you reflect on mine, I didn't have any training on this. Everything I had has been postgraduate, or if I did have training about it, it made no impression on me because I'd never actually saw a patient until I had a patient in front of me. So some of the training of physical therapists has been a little different and varied, especially in the States, but I'm sure internationally as well. So I think I'll talk a little bit about the training in the States and some of the work that we've done to figure that out. But basically, there's quite a discrepancy in what we are prepared to do. And if we think about the metamorphosis of temporomandibular disorder in general, and I'm just going to use the States because that's really my only frame of reference, we can think about the 1980s as the age of the malocclusion and equilibration, where it was really felt that anything related to the jaw was because the teeth position was not good, and if they could just change the teeth position and move teeth through the denture or grind teeth down or remove teeth, then they could fix the temporomandibular joint. And there was very little regard for any of the muscle contributions or indeed the central nervous system contribution to that. And obviously there wasn't a lot of evidence to support that approach, and it was expensive and it was not reversible. So then we moved from that into sort of the age of surgery, when surgical techniques got better and we're able to do things with a smaller window of opening the body part. So things like arthroscopy and arthrocentesis, etc., which really worked to try to flush out the joint. And again, focusing heavily on the intra-articular structures. And again, the evidence to support that as a routine management was not good. And then I would say that moves us then into the age of evidence-based approaches, which is hopefully where we are now or where we will continue to go. But one of the consistent themes that you're going to hear as I go through this presentation is that we need more high-quality evidence. So just before I move to the current, just a few more key dates. The AAOP, or the American Academy of Orofacial Pain, was founded in 1975, and this was more firmly in the dental sort of realm, even though its initial thoughts was to be multidisciplinary. And then in 1999, actually, a very committed group of international physical therapists led by Jeff Mannheimer in the States formed the Physical Therapy Board of Craniofacial and Cervical Therapeutics. So they were really the sort of international group of PTs that worked to integrate into the AAOP to really start to live that vision of an interprofessional organization to guide orofacial pain management and diagnosis. And I would say that there's been a big win for the AAOP recently when orofacial pain has become the newest dental specialty in the United States just this year. So I think when we're looking to the future, already just that finding that now you need to have specific training in order to say that you practice dentistry in the orofacial area will start to change the quality of care that some of our patients get. From an evidence perspective, a big leap forward happened in 1992 when the research diagnostic criteria for TMD was released. And the purpose of that document was to try to address some of the discrepancies that had happened in the literature in trying to find supportive evidence for many of the treatments that were being put forward. In that there was no there was sort of no consideration for the subtype of temporomandibular disorder that an individual would have, and instead anybody with basically orofacial pain that might involve the joint or muscle was considered to be just having a patient. That made it very difficult to find which treatments were effective for what types of patient. So having specific subtypes of patient can improve research validity by having a more homogeneous subject group with which to say a treatment is effective or not effective. And then in 2014, those guidelines were revised to become both clinically and research applicable, and are now called the diagnostic criteria for TMD. So we're going to talk just briefly about those in a little bit. But just in between that time, in 2005, the National Institutes of Health in the States funded a large multi-year prospective study of over 3,200 enrolled healthy individuals. And they followed those individuals for a number of years to see who developed temporomandibular disorder, among other things, and what were some of the associated factors that led to the development of TMD. And again, this is moving away from the idea that TMD is a tooth-related issue or a bite-related issue, and recognizing that there's much more at play than just muscles and joints for these individuals. So here are just two studies, but the one on the bottom right would be the one that you might want to start with, and that's the sort of gestalt or the overview of a 10-year history of some of the findings that they came from those studies. And so really they're trying to pick out what were some of the associated factors that might make a patient more likely to develop TMD. And then I think we can start to use that information for understanding why some individuals with TMD, or maybe even the majority of individuals with TMD, have a persistent pain presentation. So some patients get better within a week or two, some seem to carry on and on and on. And what is it about those individuals that we are missing in the current treatment approaches that we use? So the number one factor that came out was trauma to the joint. And obviously, if this happened to you, you could imagine that your jaw might hurt too. But trauma is more than just this large-scale trauma. Trauma includes anything that could traumatize the muscles or the joint, and that might be a simple dental procedure that involved a little bit of prolonged opening, or it could be a traumatic dental procedure like wisdom tooth extraction. But anything like that could tend to cause a trauma to the joint that would significantly increase your likelihood of developing TMD, and this was one of the associated factors. Intubation is another one, another form of trauma to the joint. People who have been intubated for any period of time might be more likely to develop TMD. And then the last one is anybody that has a whiplash-associated disorder has a higher preponderance of developing TMD also. So trauma is a big one. I'm going to talk a little bit about dental trauma in a little bit, but let's talk about the other associated factors first. Bruxism comes out to be one of the top factors. If you have a significant history of bruxism, you have almost a 17-fold increase in the odds that you will develop TMD. And bruxism, we had a fantastic webinar a few weeks ago looking at bruxism and expanding our definition away from just clenching and grinding, but including some of the other oral behaviors and abnormal parafunction that some of our patients are engaged in. But looking considering a patient's parafunction is going to be very important in our history and our observation of the patient during our examination. So joint noises are an interesting one because this is often a question I get from our students. My joint makes noises when I open and close. Does that mean I'm going to have a problem? And there's really only a weak association with joint noises in the absence of any other symptom with the development of TMD. Almost 30% of the controls had joint noises on examination but did not develop TMD. So joint noises is not one of them. The other factor that I often get asked about from students and patients is orthodontia. I wore braces on my teeth when I was young. Could that have caused a TMD? There was only a weak association in this opera study, a wearing of braces. But when one considers that it might be not just be one single factor, but a constellation of factors that could potentially predict who develops TMD, then we might think that a patient who has abnormal parafunction, who has joint noises and had extensive orthodontia, is it possible that in that individual that they might be more likely to develop TMD? I think that might be reasonable, although we don't know that yet. Headache is another predictor or associated factor, I should say. But I find this one the most interesting, and that is the frequency of somatic symptoms. Individuals who are more chronically unwell, and by that I mean people who report illness such as fevers, sore throats, general malaise, fatigue, dizziness, at least once a month, had an almost 2-time increase in the incidence of TMD. So just being generally unwell is not good for your musculoskeletal system, but particularly your temporomandibular joint. And another factor that came out, but then was the sensitivity to pressure and applied pressure. But they did a follow-up case control study here, looking and kind of concluded really that it was more a consequence of the TMD and not necessarily a predictor of it. So these are certainly some of the factors that we're going to need to consider in our patients with TMD. Two other things that came out kind of interesting are the genetic. Are there some genetic factors that might, again, make somebody more likely to develop TMD? And the glucocorticoid receptor gene, which works on the HPA axis, which is your link between sort of the central nervous system and the adrenal system and your endocrine system, that's your stress response system. So it does seem like there is maybe a genetic link there. And another one is the serotonin receptor gene, which really works on looking at affecting the sensitivity and the nociceptive and effective pathways. So potentially there's a genetic thing, but we don't know anything about the penetrance of those genes yet, but more to come hopefully on that, because potentially we could start to understand a little bit more about who's at risk from that. So that's enough about the past. Let's talk a little bit about the future and where we are right now. And there is some good news there. Several key groups have come out with important statements that are strongly related to something like this. This is from the American Academy of Orofacial Pain, but also the American Academy of Dental Research has come up with something very similar. And it basically says that unless there's a really good reason not to, treatments for TMD should be conservative, reversible, and evidence-based modalities or therapeutic interventions. And if you think about what does that mean or what does it not mean, well, the 4 things that it seems to come out with are these things: oral appliance therapy, some forms of oral appliance therapy, pharmacological management. So the first one might be dentist, the second one might be more either dentistry or medicine, and then behavioral modification, which might be by a psychologist or also by using physical therapists might use behavioral modification techniques, and then physical therapy. One of the things that I have found in some of the work that I've been doing is that some of the older literature on physical therapy was actually not how we define physical therapy ourselves. So physical therapy is that targeted intervention that's aimed at alleviating the movement dysfunction or the movement problems that people have. And it uses a variety of techniques. But sometimes in the TMD literature, especially in the older dental literature, physical therapy was described as any kind of electrical modality, not exactly what we would consider physical therapy. So sometimes we need to educate our colleagues that physical therapy alone does not mean just the application of ultrasound or electrical stimulation, but is that individualized plan of care that we give to our patients. And again, I would say that physical therapists use behavioral modification techniques, and we'll talk a little bit about that in a minute. So I mentioned the diagnostic criteria for TMD, and those were revised and for clinical use in 2014, and they're very straightforward. And obviously, you know, in their simplicity, it's nice, but there's plenty more to the patient than just their physical diagnosis. So axis 1 is the physical diagnosis, the behavioral, you know, the biological system. Is it a disc problem? Is it a muscle problem? Is it some combination of that? And what was revolutionary about this, is, at least for I think dentists, was the attention to the axis 2 side of things, which is not actually new for physical therapists. This is something we've been embracing in our profession for a long time. But it's understanding that the pain-related psychological dysfunction and distress, the fear, anger, anxiety, depression that these patients can exhibit, either they have pre-symptoms or as a consequence of the symptoms, can profoundly impact their physical manifestation of any problem they have. And if we just attempt to treat patients with the physical diagnosis alone, there's going to be a significant portion of those patients that we're going to fail to help. So one brace or one physical therapy treatment is not going to be enough to help these individuals. We need to look at the individual in the context of their own life. So I like this sort of Venn diagram to think that really we were trying to get to the sweet spot here in the middle of the combination of recognizing the biology of the individual, the psychology of the individual, and the socio-cultural influences that that individual has. And if we can find that sweet spot, then we will most likely to be effective for our patients. And although this is a shocking diagram here, I put it up to remind me to talk about the fact that pain is a perception in the brain, and it can be profoundly impacted by the cognitive mindset that an individual has. So in this case, this individual is expecting this pain to be pleasurable and to derive some pleasure from that experience. And so not all pain has to be negative. We can use that to understand the individual's mindset and then help them to understand that there are other ways to perceive that discomfort and move through it. So for me, the magic of the physical therapy examination really lies in the history and the time that we spend with our patients. So although I could tell you all the fantastic questions to ask, spending time with our active listening techniques and really finding out about those other pieces beyond the symptoms, those socio-cultural and those psychological distress items, can do as much for helping you to understand the complete picture of the patient so that you can plan the most appropriate treatment. So I think about it as about putting a puzzle together for our patients. We need to use our clinical reasoning skills to really not just put the physical diagnosis piece together and put a label on this individual, but to understand what's brought them to this situation and what we can do to change and help them to embrace that change as much as anything else. And then from a prognosis perspective, we need to understand that understanding the specific subtype of TMD is important because it might have changes for the prognosis. For instance, people with more of a myalgic subtype of TMD tend to have a greater likelihood of developing central sensitization symptoms. The other thing about the puzzle that we're putting together is making sure that we're using our strong differential diagnosis skills to rule out other conditions that can mimic TMD. So it's not just about opening and closing your mouth and seeing how the joint moves, but making sure that we are truly screening for other forms of general health issues or systemic issues. So if you're new to temporomandibular disorders, or you'd like a bit more of a review of the conditions and the application of the diagnostic criteria for TMD, I'm going to provide this article to Jan to send out to you afterwards. But it's from Ann Harrison and her group at the University of Kentucky. And they did a really great job in relating the diagnostic criteria for TMD to physical therapists and showing how it kind of fits in to a physical therapy evaluation and the way that we tend to think about things. So this does go through a little bit more about the different conditions, the different subtypes, and some of the diagnostic tests that we tend to use or that are supported in the diagnostic criteria, as well as some of the things that are not covered in the diagnostic criteria, such as the cervical spine considerations, etc. So I'm going to suggest that this would be a great article to start with if this is something you're interested in learning a little bit more about. But I talked about the magic of PT being a little bit in the examination and the time that we spend with our patient. And I believe that that time that we spend building our therapeutic alliance with the patient is one of our biggest weapons that we can use to help combat the temporomandibular disorder. So one of the things that we have to make sure that we're not doing, or we have to spend time overcoming, are some of the words that our patients have heard from other healthcare providers or including other physical therapists. Things like wear and tear, your disc is out of place, your condyle is so deteriorated on X-ray, you've lost space between your condyle and your bone there, and it's really bone on bone. Your joint seems to be crumbling. It's those words, those use of words that can harm or versus healing, as Adrian Lowe likes to say, avoiding catastrophic language and trying to spend time undoing potentially some of the words and stories that they've heard from other healthcare professionals that perhaps are not practicing in quite such an evidence-based approach. So when I read this article in 2014 by Fuentes and et al., it changed my practice fundamentally, and it set me on a road of trying to understand a little bit more about the neuroscience of therapeutic alliance. And so in this particular, I just think it's such a brilliantly simple study, very well done. But in this particular group, they had four groups of individuals with low back pain. And the first two groups here, AL and SL, had either an active treatment of interferential current or a sham treatment of interferential current. And the L stands for low therapeutic alliance. They didn't do anything special beyond explaining what the treatment was supposed to do and the normal things that you would say to a patient receiving electrical stimulation. On the y-axis here, we have pain intensity, and this is actually an inverse. It's the higher this is, the more their pain decreased after treatment. And you can see here that between the interferential group who received the active treatment and the interferential group who had the sham interferential, there was a significant reduction in pain just with the interferential treatment. But over here, we have the active interferential group, and again, the sham interferential group, but this time they had enhanced therapeutic alliance activities. That means that they were spending time during the treatment building that rapport with the patient, using motivational interview, motivational language, using change language, showing empathy, engaging the patient in conversation and really getting to know them and to enhance the patient-practitioner relationship. And look at the significant increase in reduction in pain compared to the active with low therapeutic alliance. And again, just using therapeutic alliance with a sham treatment was still better than sham treatment alone. So to me, this was like, wow, this is really, is this what separates a really great clinician or a good clinician from one that's just okay? Is it not the number of treatments I have on my toolbox? Is it not the number of or skill of my manual therapy? Is it as much about the way that I interact with patients? And when I think about many of the individuals that I look up to in this field, it really is, they have a complete package, but this is certainly part of what they do. They also had another dependent variable where they looked at pressure pain thresholds and basically found the same thing. So this wasn't just a subjective, but it was an objective finding as well. So if we just look at the exam, I'll just try to point out what some of the things are from the diagnostic criteria as well as from the physical therapy exam. Usually the first thing that I would do for an individual is to look at the way that they are at rest. How are they when they're talking to me? What can I see at rest? Are they engaging in any abnormal parafunction? Are they holding their head in a certain way? Are they overusing their shoulder? What's their breathing pattern look like? What's the position of their head and neck on their torso? And how guarded are they in their movements and how symmetrical are they in their movements? And then I might look at the way they're moving. It's a little jittery here, but you can see we're looking for the pattern of opening. We're looking for any deviation that's uncorrected at the end of opening or a deviation during opening that it becomes corrected. We're looking for the general quantity and pattern and how effortful this movement is. And then certainly when we compare that to different patients, we're going to have different patterns of findings. And we can see on this individual that she has, she has a completely different pattern of opening than the previous individual right here. And we can see that there's a clear deviation in her opening and it seems to be quite limited. So in terms of just a visual pictorial of the examination, I just would run you through. Again, we've spent time looking at posture and resting position of the jaw. And now we've looked at the quality of movement, but now we're going to look a little bit more at the quantity of movement. So using any kind of device we have, whether that be a plastic ruler or a paper ruler or a metal ruler that we can sterilize, we're looking to see if we can quantify how much opening there is without pain, how much opening there is with pain, and then how much is maximal opening. And then we can provide a little bit of overpressure to see how that changes the symptoms. And remember that anything less than 40 millimeters of opening is considered limited, according to the diagnostic criteria. The problem for me sometimes in having a hard number like that is that some patients have a very small mouth and some people have a very large mouth. So 40 millimeters for some people is quite limited and for others is just a little bit limited. And then we're looking at lateral deviation. We're looking at the symmetry left to right. We're looking to make sure that it's roughly 8 to 12 millimeters from left to right, and we're looking for how it's reproducing symptoms. And the diagnostic criteria spend a fair bit of time talking about recognizing, is this pain or a symptom that the patient having familiar to them? Is this their pain, or is this just a symptom? And again, they think about familial pain in the face and jaw, or familial headache are the two questions that we continually ask our patients. And then obviously considering if there are joint noises, or making sure that there aren't any joint noises potentially during opening, where they are in the opening pattern. Are they at the beginning, at the end? Are they both on opening and closing? What's the quality of the noises? Is it more crepitous? Is it more of a click? Is it more of a clunk? And we think that that might tell us something about the way the joint is functioning. Then I usually take a break at that point and have a look at the cervical spine, because they're in sitting at that point, and I'm really focusing on the whole cervical spine and looking again at that pattern of movement. How are they moving? How's the curve reversing? How effortful is that for them? And what general pattern, how are they starting the movement? Are they going straight forward? Are they nodding first? Are they rolling down? Like, what does that really look like? And then at some point, I'd like to look at the upper cervical spine particularly, and I like the upper cervical flexion rotation test, because that locks out the lower cervical spine and just looks at limitations in the upper cervical rotation to give me a general movement restriction, thinking that you need at least 40 degrees each way for that to be considered relatively normal. And then we can go ahead and start to look a little bit more specifically at the joint, either through looking at the arthrokinematics or the joint play at the system, both in the TMJ and the upper cervical and lower cervical spines. And then, although special tests are not officially part of the diagnostic criteria, I do find them helpful to do some joint loading, either manually, and also to do some muscle resistance to try to see if any of those will reproduce the patient's symptoms as well. And then something like the dental stick or the joint loading test, where you have an individual bite very hard down on one side, and if it's a joint problem, it should relieve the pain because we're unloading the contralateral side. If it's more of a muscle problem, it will be a little bit more painful on that ipsilateral side. And then I always look at cervical function from a neuromuscular perspective. I like the craniocervical flexion test or the flexion endurance test. Both of those tell you slightly different things, but really seeing, can they activate those deep neck flexors without activating the superficial neck flexors like the SCM or the scalenes. And then for me, it's also looking at what do they do with their jaw when they're doing that movement. And a lot of times we'll see patients bracing or holding during a neck movement. And then even though they deny any bruxism or holding or bracing, that's typically when I start to see it coming out, when they're not thinking about their jaw and they're starting to use their neck. So the ability to disassociate neck movement from jaw movement. The jaw should stay relaxed during that movement. And then I typically say things like palpation, both intra and extraoral, looking not just at the masticatory muscles, but all of the cervical structures all the way down into the mid-back, usually at least, to the end, because typically this is fairly uncomfortable. The diagnostic criteria do specify the amount of pressure that you are to apply and for how long. I think that's mostly important from a research perspective, but making sure that you are holding some of that pressure long enough to see if there's any referral of symptoms. So I would say in general, that's sort of the gestalt of the evaluation that I would tend to do. And there are different diagnostic subsets that we can classify a patient into, and that might help us guide our treatment a little bit more. But let's just think about them basically as three groups for now. We'll talk about group one, which are the muscle disorders, group two being the disc displacements, and we'll talk about the 4 types that are currently in a minute, and then group three being our joint dysfunctions. And again, if we have a disc displacement, one of the key criteria is it impacting motion? Is it limiting motion, or is it not limiting motion? Is the disc reducing, or is the disc fixed in a displaced position? And then for our muscle disorders, really, is it a local muscle problem, or is it referring? And remember that we can get a lot of symptoms in this area that's actually coming from the neck. It has nothing to do with the temporomandibular joint at all. So thinking about your referral patterns into the head and face is important here too. And here's an example. I'm going to make the link available to this website, which is a free website that you can access, which shows you all of the diagnostic criteria for each of the different subtypes and how you would confirm any one of these particular bubbles down here, which represent a subtype. However, recognize that almost every patient will have more than one bubble, and the actual diagnosis is the simple part. Where the complexity comes in is one, making sure that they truly have TMD, so spending time ruling out those other disorders, but then thinking about those other factors that can impact them. So if we just take a minute and look about the disc displacements, I said I would mention the 4 because I think this is often a little confusing. So this is the preferred terminology now. A disc displacement with reduction is where the disc is displaced at rest and then reduces or comes back to alignment during opening and then displaces again at the end of closing, versus something like a disc displacement with reduction, where the disc momentarily impairs the condylar movement and can actually lock or make the joint not able to open or close. And then we have situations where the disc doesn't reduce, it's always displaced. It's either blocking the condylar translation, so the mouth cannot open, or it's displaced, but the mouth has regained its full motion. So understanding each of these might change your treatment approach quite significantly, depending on which one they have. Now, when I've talked to some dentists in my area, they tend to think about physical therapists working more with muscle disorders, and there is some resistance to the fact that we can do anything for some of these joint and disc disorders. And so we should probably spend some time talking about that in just a minute. So what kind of a patient might show up into your clinic? Well, Steve Krause and I started a series of papers a few years ago, and the first one was Steve's paper where he had heroically captured the medical records of almost 600 patients as they came through his clinic with a vast array of demographic and clinical findings. And this paper came out, and it was kind of an interesting paper to say, what does the typical patient in an outpatient clinic who's referred to PT from a dentist look like? So this, he ended up with 511 patients in the sample, interestingly, of those 511, he had to, there was more, but he had to exclude at least 3 and send them back because they actually had something that was not TMD, which is what I just spoke about. One had nasopharyngeal cancer, one had a blocked parotid gland, and one had a cracked tooth. So not every patient referred from another medical provider, you know, we still need to do our due diligence to rule out other conditions. So I mentioned earlier this affects women more than men, and that was true in this population. That means that these patients were seeking treatment, and he had about a 5-to-1 ratio. I've seen it a little higher in the general population. The average age of his population was almost 44 years old, but only a small percentage of them actually had a formal diagnosis of TMD. The rest of them had more of an evaluate and treat kind of diagnosis or referral. But I think part of that is because Steve Krause has spent a fair bit of time working with his professional network, and those dentists really respected and trusted him and didn't feel that they needed to guide that in any way. But in some cases, he had almost 65 dentists referring to him over this period of almost 2 years. And sometimes he had just sort of nonsensical referral diagnoses like ligamentitis and things like that, or some dental nomenclature like open and closed lock, etc. So you might get a little bit of a mixed bag in terms of people referring these patients to you. So why should a dentist refer a patient to physical therapy? Well, in this particular study, it was because that was what the dentist chose to do before they were doing anything invasive or aggressive or non-reversible, which is exactly what the evidence would hope that we would get. In some cases, they were considering surgery, or something really aggressive, but they wanted to see how many of the symptoms could be knocked down first by physical therapy. And again, I think the only reason that Steve saw this many patients in this category was because he had spent a lot of time working with his partners in the dental community there in Atlanta to really build those relationships professionally so that they knew what he was capable of and how he could help them with their patients. And then in some cases, the patients had been seeking treatment from multiple healthcare providers, were not getting better, had significant interventions, and the dentist recognized they just needed to get them to somebody that potentially knew how to help them in a different way. And then lastly, the other main group was individuals who developed TMD as a response to dental intervention. So I mentioned earlier that trauma could be something like a dental procedure if they were open. So how long do you have to be open for it to be trauma? And there's no guidelines for that. For some patients, it's while they're doing some sort of yawn and they're very wide open, and that's enough to cause a micro trauma. For other patients, we tend to think that the longer the dental procedure, the more likely they are to have symptoms. But there's some animal work that suggests that's given us some clue into this. And this was a study that was done on rats. And they took two groups of rats. Both were anesthetized with isoflurane. One was the control rat group, and the other group had the anesthesia, but they were kept in maximal mouth opening for 20 minutes. And what we're seeing up on the y-axis here is the number of nociceptive pain withdrawal responses. And you can see the higher the number, the more in pain, presumably, the rat was to the stimulus. And at baseline, there was no difference between the two groups. But even within 2 hours, there was a significant increase in nociceptive head withdrawal responses, which took almost a week to go down. Even at 2 weeks, there's a little bit of a hint there that it's not quite down in all of the, although this difference was not significant. And how long they were open for was just 20 minutes. The other interesting thing is when they sacrificed these animals, they also looked at cytokine expression and found that there was a significant increase in cytokine expression in the trigeminal ganglion for the rats who were kept open for 20 minutes, as well as in the upper cervical spinal cord. So that trigeminal system was sensitized by just this 20 minutes of opening. So this might be something that we need to talk to our patients about when they're going for their dental treatment, to make sure that they're taking frequent breaks and not staying open for too long. Although we don't for sure know, I don't imagine too many humans would want to have this done to them at this point. So I just took the data from Steve, and he let me create a few diagrams here. But the reason people are coming to physical therapy is because they have jaw pain or face pain in some way. But the other top reasons that they're coming is because it's impacting their ability to open their mouth, their joint is locking, and it's affecting their ability to function, or they have some just joint noises, joint popping in some way. But certainly, the other thing is their average pain response is sort of a moderate pain level, around almost a 5. But interestingly, almost half of them responded yes to at least one of the fear, anger, anxiety, depression types questions, which is fairly high, but perhaps not unexpected given everything we've talked about so far. So if they're not coming just for jaw pain, what else are they complaining about? Well, the most common complaint that they also have is neck pain, which is probably why physical therapy might be a good idea for some of these individuals. The other thing is a non-migraine headache. Could be cervicogenic, could be a secondary headache, could be a TMD headache, or it could be a primary headache disorder. Bruxism or other abnormal parafunction. And then ear symptoms. We had another fantastic webinar a couple of weeks ago on tinnitus. And I found that one interesting too, but it might not just be ringing in the ear, it could be pain, it could be fullness, it could be hearing loss, etc. And then look at this yellow-orange wedge over here. These have low back pain as well, suggesting that people that have facial pain here might have pain in other areas of the body too, which is also supported by the literature. There's a higher incidence of patients who also have things like fibromyalgia and TMD, or migraine and TMD, etc. Irritable bowel syndrome and TMD. So there's definitely some association with some other more systemic chronic pain conditions. And then finally, dizziness and migraine with some of the other common complaints. And obviously this adds up to way more than 100%. And that's because most patients have more than one complaint when they're coming in. The average number of healthcare professionals they saw was about 3, which I thought was pretty good, but it was quite a wide range. And then 54% of the patients wore at least one oral appliance. I think the average number was anywhere between, the number of appliances went anywhere from 1 to 9. One patient had 9 appliance types. And then of the appliances that they wore on their teeth, there were 11 different types. So a real mix. So in terms of what the breakdown by diagnostic category are, the majority of patients that Steve had in his clinic were myalgic disorders, or the group 1s. And then group 2 was the joint complaints, and group 3 was the disc displacement groups. And this is a little bit different than what we see in the rest of the literature. So Manfredini did a systematic review with meta-analysis in 2011, where she looked at a lot of different studies to see what the prevalence of the different subtypes was. And in that particular study, although myalgic was the number 1, it was only 45 versus 40 for group 2 and 30 for group 3. So that sort of begs an interesting question. Why would patients in physical therapy, particularly in this sample, this is all we can speak to right now, tend to have more myalgic complaints? And I would hypothesize that potentially, again, dentists referring these patients might tend to think of physical therapy helping more with muscle problems than potentially joint problems. So a little bit of education to our general colleagues about how we can help almost all of the people with TMD in different ways might be something that we would want to look into. So we did a follow-up study where we looked, one of the things we had heard, and in fact this came in Illinois, we had a challenge to our Practice Act by the Chicago, the Illinois Dental Association, saying that physical therapists were not capable of diagnosing TMD. So we did a study where we looked at the diagnostic accuracy of using the diagnostic criteria for diagnosing, in this case, just one subtype, which was disc displacement without reduction with limited opening. And here we had 92 different clinical exams, including left and right sides. And the take-home message here is that we had acceptable sensitivity, where the diagnostic criteria validity project really recommends 80% sensitivity and specificity. You can see our specificity was a little bit lower than normal, thinking about the difference between true positives and negatives here. But the clinical utility of these findings were pretty strong. The positive likelihood ratio, you're 3 times more likely. I should say that we compared this to a gold standard of MRI imaging, which is the gold standard for disc position. However, MRI is not a particularly perfect gold standard because it cannot distinguish between a clinically significant displaced disc and a clinically irrelevant displaced disc. And almost a third of individuals who are asymptomatic might have a disc displacement as shown on MRI. So we were quite happy with these numbers, and we thought the overall accuracy compared to the MRI was about 80%. We could have done with a slightly higher N and a few more negatives to make this a little stronger. But I thought that it was a nice idea to just at least start to show that physical therapists are eminently capable of utilizing the diagnostic criteria. And in fact, when you start to look, this was just a quick search of PubMed, which I did to put in the words physical therapy and TMD, you can see that there's a pretty substantial growth of papers looking at physical therapy and TMD, with a bit of a spike here 4 years ago, but this highest number was still only 28 studies. So we have a long way to go to really start to beef up some of the articles and the studies and the strength of those studies as we go through them. And one of the problems that we have found when you're designing a study to really strongly look at the effects of one intervention on something is obviously our gold standard for that would be a double-blind randomized control trial. But unfortunately, that doesn't lend itself very well to the way that physical therapists practice, because we use a constellation of treatments for the individual patient. So we need to find some way to show our efficacy in other ways. So let's just talk about interventions for a minute. And here we're thinking about things like looking at the categories of interventions: symptom reduction, education, and parafunction. Again, this has a huge impact in the patient's presentation of their symptoms. We might use things like pain neuroscience education. We might use things about changing jaw resting position. We might talk about habits, etc. We might think about working on joint mobility and muscle issues, whether that be through mobilization. For me, my dry needling has been transformative in my practice. I can't imagine practicing now without it, because it allows me to reach muscles that I really struggled to meet and be effective for. my patients will tolerate dry needling of the pterygoids much more than they will if I'm fumbling in some kind of intraoral palpation activity. Thinking about the neuromuscular control and how we're actually activating the muscles and how we're activating trying to change the relationship between the cervical spine and the jaw, and thinking about neuromuscular function, building endurance and control, and disassociating the jaw and the cervical spine. And again, thinking about restoring any mobility or gating the pain in any way. And then a fair bit of time spent on posture and again, education here. And then exercise, I just put as a general category at the end because any of our individuals with chronic pain, we need to think about adding an aerobic component to help modulate that pain as well as general exercise. There are several studies that have looked at the fact that supervised exercise by a physical therapist is stronger with better outcomes than just giving patients exercises on a piece of paper for individuals post-operatively TMD. So there's something about the interaction with the physical therapist that actually can improve the outcomes for our patient. Probably the most well-cited study to quote to look at the effectiveness and the evidence behind physical therapy is this systematic review with meta-analysis that came out of the Brazilian group. I think they're Brazilian. And the reason it's a strong one is because they try to pay attention to the subtype of TMD and try to classify which outcomes, which treatments were effective for which subtype rather than considering all patients together. And I will tell you the take-home message right now is that, again, we need more high-quality randomized control trials to strengthen the findings. But that being said, let's take a look at some forest plots here. This top one right here is looking at the effects of manual therapy plus exercise on a arthrogenous subtype of TMD. And if you're not familiar with forest plots, here are the particular studies that were included in the meta-analysis. And over here, we have a line of no effect at 0. And in this case, anything to the right of the line would favor the treatment, which is manual therapy plus exercise, and anything to the left of the line would favor the control, which in this case could have been something like rest or appliance therapy, etc. And what we're looking for is this diamond at the bottom. We're looking to see, is it clearly across the line over one side or the other, but not straddling the line, because that would show no effect. And the width of that diamond is the confidence interval. How 95% confidence that the mean is lying inside this. I can have more confidence when it's not straddling that line. So if we use that metric, we can see that it seems like there's a positive effect on the arthrogenous group for manual therapy plus exercise in improving pain-free or pain intensity. The second group was looking at the myogenous subgroup, and here there's only 2 studies that looked at that, and their active intervention was postural correction, and they were looking at maximal pain-free mouth opening, and again they found it favoring that postural treatment pretty heavily there. But when you get down to the bottom one, we're looking at the effects of general exercises on a mixed subtype of TMD. It's pretty much what we've talked about already, that it's really unlikely to have any effect because it's such a mixed group. A mixed intervention on a mixed group of patients is showing no significant effect. So although there's promises for physical therapy, we have to find ways that we can show our efficacy. And so Steve and I did another study where we looked at trying to show some outcomes of individualized physical therapy. It's not a randomized control trial, it's the opposite of that. It's saying in a cohort of patients where we treat them as individuals and we treat the problem based on a clear diagnostic criteria, how do they do? How many visits does it take? What does that look like? And just quickly here, for this particular subgroup of patients with disc displacement without reduction, the average number of visits was around 6. But you can see there's something on either side of that. Physical therapy significantly helped. Those 6 visits plus or minus helped with pain-free opening. It also helped with reductions in pain. And we also wanted to look at the patient experience with physical therapy, and patients were highly satisfied. The 3 areas that they were most satisfied or most consistently satisfied in were jaw pain and tension, the mouth opening, and then pain with chewing. And then lastly, would they come back and do it again if they needed to? And if they said yes, we would think that that would indicate that physical therapy was effective for them. The one outcome that we didn't collect, which we should have done, was cost of care, because I think we could have really started to show the efficacy and the cost effectiveness of physical therapy as a treatment approach. And then just very quickly, the training of PTs I alluded to earlier, it's a bit of a mixed bag in the States. It is required to be an entry-level DPT education. There'll be some mention of temporomandibular disorder, but just as with every other condition, our accreditation standards don't generally specify exactly what we have to cover. So we did do a study to look at how well we're doing in this. And although it was just a survey, so we're limited by who responded and what they said, the average number of hours in the educational program across the programs that responded was 12 hours of education specifically devoted to using the words temporomandibular or something related to the joint or muscles mastication. That doesn't include anything related to pain neuroscience, anything related to differential diagnosis of systemic problems. It's just the temporomandibular piece. But we had a huge range. We had some programs that were down at 1.5 and other programs that were 50 hours and up. So we still have a ways to go in giving out some more educational guidelines to say what would be an entry-level expectation and then how much of that is postgraduate education. Just as I wrap up here, the future directions, I'll keep this brief because we're coming up on time. I did wish I had a crystal ball, but I don't. But I think that we need to do a much better job working in our interprofessional education and training. So it's not enough just to say that we need to work with other healthcare professionals in the care of these patients. We need to train our new therapists how to actually do that, how to refer, how to work collaboratively, how to refer patients back and forward, and how to lose some of the jargon and the turf wars that we've experienced in the last 30 years. My colleague, Emily Kenner in the University of Minnesota brought this to my attention when we were working on a paper together about potentially how the use of 3D bone modeling might be applied to the temporomandibular area to understand the joint function a little bit more. There's been some work using 3D bone modeling in the shoulder, which is a similarly complex joint. Thinking about the temporomandibular joint, it has a floating axis, so it's very difficult to model it. But by using bone modeling, in the shoulder, they've been able to start to challenge some of the biomechanical impingement kind of models that we have taken for granted for many years, which might start to suggest new avenues for treatment. I told you earlier that I was starting to get excited about the use of real-time ultrasound for research, but also for clinical practice. This is something we've been doing in our musculoskeletal outpatient clinic for a couple of years. I do not have an elastography machine, but I really wish I did, because I think the future of that for showing the efficacy of some of our treatments is tremendous. So here's an example of the masseter. If you're not used to reviewing real ultrasound, I think you can just see that if this is one masseter and this is another one, and this is a normal picture of muscle, this clearly is abnormal. So for the ability to document changes in our muscle tissue, to look at vascularization and inflammation, and to be able to show how those our treatments are really changing at the morphology and the function of those muscles with real-time ultrasound, I think is very exciting. This is a study that we're working on right now where we're using real-time ultrasound to try to capture changes in the longus colli, which is one of your deep neck flexor muscles. Here's the carotid artery and here's the thyroid. And really, this medium really lends itself to physical therapy because it's portable and you can see the dynamic actions of the muscle. And if we could get elastography, then we could look at the stiffness changes in the muscle as well with our treatments. And again, I don't have that, but here's a longitudinal view of that longus colli too, and you can see that we could maybe do some contraction and we can capture how that muscle is changing. And then we need to do a little bit better job with understanding which particular exercises work for different subtypes. And again, I mentioned the fact that supervised exercise by a physical therapist is proven to be superior than just straight exercises. But what about prehabilitation for TMJ surgery? We know in other areas of the body, it can improve the immediate post-operative response for patients with less analgesia if they have at least one session of pre-physical therapy but that hasn't been shown or attempted to be looked at in temporomandibular joint surgery yet. And then when we think about our pain neuroscience education, I mentioned dry needling as a change for me, and pain neuroscience education is another change. This is a visual representation of the homunculus that's showing how big the different areas are represented. And I always think about how much of the area of the homunculus in the cortex is represented by the face. And so understanding how chronic pain and abnormal movement patterns can change that cortical representation, lead to cortical smudging, laterality issues, etc. I think we need to do a lot more work on understanding what some of these changes are in temporomandibular disorders. A lot of the work that's been done already is on chronic low back pain and neck pain and osteoarthritis, but there's not as much work done. I know that the Crafter group has done a good job in trying to look at laterality and come up with some apps, etc. But I think we have a little bit more work left to go. And then as we come to the end here, understanding how we can validate some of what we do. So this is an example where Cesar de la Penis, his group, used a cadaveric validation for a new dry needling approach for the lateral pterygoid. And I was really gratified when I took the advanced dry needling course of MyoPain, I think that was last year, that they are teaching this technique. So they're so evidence-based that they're keeping up. But if we can validate more of what we do and show really how it's changing function, then we can start to change people's perceptions about what we can do. And I think we can start to help our patients a little bit more. So if I leave you with a general take-home message, I would say spending some time understanding the subtype of TMD is very important. And then I would say thinking about the past and the present so that we can inform the future is probably the next thing. But leave here with an understanding that while a PT is a recommended evidence-based approach for the management of TMD, we do have still a ways to go in building our evidence portfolio and informing our colleagues. And then training of PTs in the field of orofacial pain in general is ongoing. And I think watch this space because the future is definitely bright in this area of practice. So just in closing, I want to thank Jan and MyoPain Seminars for the opportunity to talk to you tonight, but mostly for the opportunity to be part of these webinars during the quarantine period. It's really been a tremendous asset to me. I'd like to thank my colleague in Atlanta, Steve Krause, a physical therapist who is a giant in the field of TMD and physical therapy, and then my colleague at the University of Minnesota, Emily Kennert, who has been working with me on an article about the future of PT and TMD. So I guess now would be a really great time to take any questions and see what you have for us. So I'm hoping that I can have a quick look at questions. All right. Jan, I don't have any questions showing up. What have I done wrong here?
I don't think you did anything wrong. This is Jan. There's a question.
Oh, okay. Thank you. Yes, this one is showing up.
There you go. People hadn't asked a question.
They're starting to come in, so I will just let everybody take a sip of whatever they're drinking or a quick stand while the questions are coming in. Thank you. The few people are saying thank you, and I do appreciate that. And again, I want to thank MyoPain for putting this on. I think they're fantastic. Can you please give us, depending on your personal experience, the top recommended muscle to treat for TMD? Ooh, that's a great one. Let's think about that. I can't say that there's going to be just one. It's almost, I can't imagine a situation where I'm not treating both the masseter and the pterygoids and the temporalis, because, and then the digastric, of course, and then the cervical muscles. It really depends on the problem that the patient is having. Do I feel that they, if they're having something like tinnitus, then I might work more on the pterygoids because we're thinking about that connection to the ear. But if it's, I often start on the surface, on the superficial masseter, and then work down to the deep masseter because the patients tend to tolerate that a little bit more. When I'm doing dry needling, I don't often start with the pterygoids. I see how they do with the masseter first. I can give direct pressure over that muscle, and I can see if they're flinching. I might choose whether or not I do a more aggressive dry needling approach. So I would say start with masseter, work your way to the pterygoids and the temporalis, and then, but most importantly, don't forget the cervical spine muscles. Very important now. It's working. We're just absorbing too much information. I'm sorry. That was a bit of a whirlwind tour through the past, the present, and the future. So curious what continuing education you would recommend for more TMD. Wow, another great question. I think the future is bright there too. I think we have the Crafter Group in Europe, which have brought through MyoPain to the US now. That is one strong organization. I think you could look into their training for postgraduate training. I also think if you consider, if you go to the Physical Therapy Board of Craniofacial and Cervical Therapeutics, they usually have a list of upcoming continuing education sites, courses too, that they support because they are evidence-based and they know that the therapists that are putting on those courses have done advanced training. So I would probably start with those two. I have noticed an uptick in my personal mail of people advertising continuing education for the TMJ area, and I haven't been terribly impressed with some of the words and the language that they're using. So now that you've had this webinar, maybe you could look at some of those objectives from the course to make sure that they're really using evidence-based approaches and not just kind of guru approaches. So curious, yes, thank you. Oh, Harry, thank you. I really enjoyed your lecture. That was Harry von Pickart's. That was a great lecture he did a few weeks ago. Thank you from Lebanon. I'm from the UK. Oh, it's someone with a similar approach. Thank you. I should have said at the beginning, I am from the UK, but I've been in the States 30 years now. So I actually sound Australian, as I've been told. And if not Australian, then I've also been told I sound like I'm from Texas. But whenever I see my parents every year, they always tell me I sound like a damn Yankee. So, so yes, thank you. Hi to you, UK. We're hi to Lebanon. Wow, this is really tremendous to see all these different people. Do you have a suggestion on where to start with an individual complaint of ear pressure? Yeah, it's interesting. I have a patient like this just now who doesn't have any pain at all and has never had pain, no joint noises, but it's just ear pressure, not ear pain, but just ear pressure, and has been through multiple healthcare providers, including a full MRI and a workup through the otolaryngologist, who now works, who referred him to me because he basically was a last resort. And we've had some really, I've had some good work with him. And interestingly, we really worked on his parafunction first before I went after any particular targets. And he was not aware that he had abnormal parafunction, but he had a strong bracing response to any head movements. It was kind of interesting. And then for him, dry needling of the pterygoids proved to be the magic for him, because that was when he started, I was able to reproduce that ear fullness and then eliminate it. It took about 3 treatments. So that was a success story for sure. So I would say for ear, I often think about the relationship of the pterygoids to that eustachian tube. Think back to the tinnitus webinar of a few weeks ago. There's a few other targets in there too. But then also I think about the relationship of the mastoid, all the structures that are attaching back here and sort of mobilizing back here and getting some of this loose to sort of just change that relationship back here. Would I recommend any particular training for real-time ultrasound to be used in the cervical facial region? Yeah, wow, that's a fantastic question. What I did originally, I just got into it from a general perspective. So I took a pre-conference course put on by the imaging SIG for the American Physical Therapy Association, the orthopedic section. And that was my first introduction to the possibilities for real-time ultrasound and physical therapy. And then I took a series of courses through the American Institute for Ultrasound Medicine, looking at the MSK ultrasound, and that's sort of the whole body. But the one area that they don't cover is the head and is the face. They cover the thyroid, but they don't really cover the temporomandibular joint. So I've had to do a little bit of self-learning, and I'm still trying to find some good mentors in this area. Jim Elliott in Australia has been really helpful. But I would say watch this space, because maybe I'll be the one to start training you. But right now, there's nobody that I know of that is specializing in that area. I did see that AAOP this year has a virtual conference, and one of the sessions that they're offering is actually the use of real-time ultrasound for TMD. So I'm going to be excited to see that and look at that. So maybe I'll let you know if I find anything interesting there. Do I use resistance exercises for jaw muscles, or do you find it causes just too much compression or hypertonicity? Yes. Resistance exercises, to me, strength is not generally the problem for the jaw, but I might use resistance to work on more of that reciprocal inhibition or more of that central inhibition. So light resistance, but not necessarily strengthening activities. So resistance to deviation, so thinking about resisting, if you're thinking about the left pterygoids, thinking about how they have an action towards right deviation, resisting that motion so that you can get activation of those muscles followed by the inhibition afterwards. So light resistance. Sometimes I'll use resistance as a guide to motion to improve the quality of motion, but not for strengthening. I've seen a couple of activities through YouTube where they're recommending sort of this spring thing to strengthen your jaw muscles so you get these chiseled cheeks. And I'm just sort of shiver when I see that. Oh, I'm saying hi from Jeff Mannheimer. Oh, hi, Jeff. Thank you so much. Jeff is the president of the organization I was talking to you about. So that's nice to see people that I really look up to here as well. So I'm glad I didn't know you were on here already, Jeff. So resistance, tendonitis. What are your thoughts on tendonitis in the temporalis on our masseter? Yes, I think it's a very real problem. You can palpate the coronoid process to get to that tendon of the temporalis and get some sense on that. And I think, is it really the tendon though? Or, you know, the tendon itself is fairly short. There's a huge amount of connective tissue before you get to muscle in the temporalis. And I often think about, rather than here where it's generally very, very painful to touch, certainly we could do some treatments here in a mouth open position to sort of get to that insertion of the tendon, but maybe we could work at the muscle from the other end where it's a little bit less painful. I definitely think that is a possibility too. The rest of the muscles don't really have a tendon. The masseter, the pterygoid, well, the pterygoid does, the lateral pterygoid does, but it's very, very short. It's primarily a lot of muscle. So I would go after the muscle before I probably went after the tendon a little bit there. Oh, I'm saying hello from one of my ex-students. Hi, Eric. It's great to see you. Thank you so much. What is my thought on TMD, resting position, and affecting positioning for sleep? Yeah, that's a really big one. So the resting position of the jaw is something that patients often have difficulty understanding what that is. They think they're resting, but their teeth are always touching. So remember that the teeth are really not supposed to be touching more than about 20 minutes a day when they're chewing, but not necessarily when they're just stopping or when they're talking. Their teeth should not be together. And just that simple explanation to the patient that I want you to catch yourself anytime your teeth are even coming close to touching might be enough to start to trigger awareness. One of the problems that I do see in some of the quality outcome scales, like the jaw functional limitation scale, etc., or the oral behavior checklist that we might use with patients, is that sometimes they're completely oblivious to their jaw position or their parafunction. And then we give them that scale and they don't score very high on it. And then through treatment and through education, they start to become more aware and their scores actually go up, indicating they're getting worse, when really they're just becoming more aware. So I do think that jaw awareness and position and just that relationship of what their jaw is doing. I have one patient now that every time she opens her mouth, she throws her head back all the way. That's just how she's learned to adapt to this problem. Do I think tinnitus is highly related with the TMD? I think it can be for some individuals, but not all tinnitus is TMD for sure. But for some patients, we had that webinar a few weeks ago. That was a really great one. I would go back and watch that one if you'd like to hear a little bit more about tinnitus specifically. But yes, I definitely think for some patients, there's a myofascial component to that for sure. A couple of people are saying hi to Jeff. I'm not sure he can see who's saying hi to him, but Emily Canner is saying hi to you, Jeff. Have I seen any literature that supports the use of joint manipulation, like a grade 5 manipulation of the TMJ? This person, Lewis, oh, hi, Lewis, saw a video of it, wasn't sure how to feel about it. Yeah, that's an interesting one. The only time I would consider using a thrust manipulation for the jaw is in a situation where I wanted to produce those centrally mediated relaxation effects. So something like maybe an individual that had, like the individual I told you about at the beginning that I failed miserably. It turned out he really didn't have TMD. He had a post radiation trismus. And a patient like that might have done well with some sort of a high velocity thrust, but it's not part of my routine practice for the jaw. But I do use a fair bit of cervical manipulation, but I also use a little bit of upper thoracic manipulation. And for me, that can help gate some of their pain. And if I can improve the motion in those segments, then sometimes that can improve the whole relationship. Patients that have a difficult time relaxing to do a thrust manipulation at the jaw. And I think that's, if I miss, I'm going to scroll back to the top in case I've missed anything. But I believe that that is everything. Jan, are you seeing anything I haven't? Just curious.
I think you missed a question about protrusion by Divya Joshi.
Oh, thank you. C1, C2, flexion dysfunction. Is protrusion as in posture? And is protrusion as in posture? I'm not quite sure, but maybe I didn't say it correctly. So when we think about protrusion, we think about the jaw going forwards and back. So it's sort of in that horizontal transverse plane. Posture can be any change in any position. And again, when we think about using protrusion movements, we might use a protrusion test to see if that changes the clicking, reciprocal clicking. So if you ask a patient to protrude their jaw and then go ahead and open, if it's a reciprocal click, a disc displacement with reduction, oftentimes that click will disappear. And that can be one way that you can help sort of whittle that down, but that's not really part of the diagnostic criteria. Is C1, C2 flexion dysfunction common in TMD? Absolutely. I would say it's one of the most comorbidities that I see. A lot of times I recode any referral to include a cervical component. It's rare that I have a patient with long-standing TMD that doesn't have some cervical compensation, because in the States, sometimes it's a little bit easier as well to explain to people that they have a cervical as well as a temporomandibular component, the insurance companies as well. All right, Jan, I'm hearing you typing. Oh, somebody's typing. Thank you for this webinar. I believe that's everything I have. Thank you to everybody that's thanking me. I really have enjoyed this. Thank you so much. I want to thank Jan again. And then I'm going to send Jan a couple of articles to include in the post-webinar email with the recording. So I think we will end there. Thank you, everybody.